So we'll start with a panel discussion without wasting any time. Let me call about Dr. Rohit Pai is here. Dr. Preetam Kataria. Asha, just see if
So,
Preetam is outside.
yes.
Dr. Vikas Talreja. Dr. Sangeeta. Yeah, I can see Sangeeta there. And Dr. Sandeep Ishi is also here.
Yeah. Dr. Vijay Patil going to moderate a session,
Yeah.
panel discussion on the same topic.
So we won't talk about the same topic.
Thank you.
Okay, because he already has made a case for Exon 20. So at present, how many of you have seen at least one case of Exon 20 insertion? Can I have a raise of hands? Okay, there are a few raise of hands, and those are from my colleagues in TMH only. Okay, so first of all, you won't catch Exon 20 insertion unless you do a comprehensive genomic profiling. Am I correct? That's right. So we'll start with from Sandeep. No, Sandeep has picked up the mic. Sandeep, when you see lung cancer upfront, how many times you do a comprehensive genomic profiling?
Sir, if we are not discuss the financial aspect, I always offer
Correct.
in adenocarcinoma in all the patients.
Sangeeta?
If cost is not the factor,
Yeah.
then
So
definitely.
understand, for this discussion we'll keep cost aside a factor, because if cost is a factor, he cannot afford amivantinib. So we are talking about those people only who can afford amivantinib. So we would do comprehensive genomic profiling. Now, Rohit, what do we mean by comprehensive genomic profiling?
So, sir, I believe that in lung cancer, we can consider a panel of 12 to 15 genes as a reasonable comprehensive genomic profiling.
So what Rohit told is a clinician's point of view. Now, when you say comprehensive genomic profiling, and you may get this question in your exams, you are not looking at 100 genes, 72 genes or this. When you say the word comprehensive genomic profiling, means you are looking from all directions. You are looking for fusions, you are looking for amplifications, you are looking for mutations, all sorts of mutations. Now, many times in the definition of comprehensive genomic profiling, it also comes whether you are going to get a report of tumor mutation burden. Now, the tumor mutation burden report cannot come on 12 genes, 70 genes or 80. Reasonably good sensitivity reports will come only when you have 300 and 400 genes. And that's the reason why sometimes we will get confused that CGP है मतलब बड़ा gene panel होगा. That is for tumor mutation burden, but CGP in itself means that you are looking from all angles, which means all types of mutations. There is missense, point mutation, translocation, fusion, translocation, type of fusion. You are covering for all of them. Now Preetam works in something in Mumbai, what is called as SOBO, which is South Mumbai. Preetam, when you look at an upfront EGFR report comes positive, what are the factors you look in that report, genomic report?
So when I get a EGFR report, I look at what exactly it is, whether this is exon 19, 20, 21, and so on, and other like LET5, 858R, and other mutations which are there. And based on that, what is the sensitivity to the available TKIs? That is what we are more interested when we look at the EGFR report.
Would you look at, and Rohit was only presenting yesterday, Rohit, would you look at other mutations apart from EGFR?
So, yes, sir. So, co-mutations I think are important. P53, both for EGFR and ALK has demonstrated.
Correct.
Inferior.
So not only you look at the EGFR type, you also look at the co-mutations type. And at present there is reasonable data for at least for P53. I'm very sure as we go ahead, we might get data for other mutations. Now, the panel was for Exon 20. We are hardly going to discuss Exon 20, but one question. If you get an Exon 20 insertion, what do you do, Sangeeta?
So generally, like you said, the CGP profile, I usually talk to the pathologist, to know what the mutation exactly is, if at all, if there is some sensitizing in the exon 20, and then definitely offer them the options of therapy. If the cost not factor, obviously discuss the role of amivantamab.
Okay. So one of the first things you told is that you need to discuss. So understand there is not, exon 20 insertion is not like there is one insertion. Exon 20 is like India. You would have people from Maharashtra, Bengal, Tamil Nadu. So exon 20 has many types of insertion inside. Interestingly, there are few insertions, at least one type which I know, is even sensitive to the first generation TK. So it's important that you discuss this exon 20 report in your molecular tumor boards and get an idea whether is this sensitive to the first generation TK. And if not, at present the data is in much favor of amivantamab. And that would be an option which you would use. Sandeep, what is your fear when you use amivantamab?
The first thing, I never use. Second thing, the data shows it's
Okay.
hard to.
Fantastic. So I know Yashwant and Preeti had raised their hands. That's in exon 20 insertions. What is your fear when you use amivantamab? Correct. Yashwant? Correct. So these are the two more things, and we'll first see there is no rocket science. If your patient is affording in today exon 20 insertion after molecular tumor board, if it's not sensitive to your first generation TKI, amivantamab is unfortunately or fortunately the only option at present which works. There are options apart from this which are something called sunuvozin and flumitinib, but they are not available in India. So we will focus on amivantamab. Now the issue with amivantamab is amivantamab does lead to a lot of side effects. And these first side effect is infusion reactions. And let's look at this. There are multiple data which have been shown, and you could see that the all grade reactions are seen in 60 to 40% of the patients. The severe reactions are seen in below 10% of the patients. And this is one of the things you are going to counsel your patient, that reactions are a part and parcel of this therapy, and in the first cycle you are likely to get a reaction, the probability which stands at nearly 60%. And please, when you are administering amivantamab, please keep anti-allergic drug available with you, and at least do a continuous monitoring of the patient, so that if he develops infusion reactions, you have to tackle them. Now what I am going to show you is that most of these reactions happen in the first cycle. So this side is Nasik. He has unfortunately not given anything. I am very sure you would have given. And how do you give the first cycle of amivantamab?
So what we do is we start with the pre-medications.
Correct.
And so we give Avil, hydrocort, Dexa and everything. And we adjust the rate. So,
Correct.
First will be 12.5,
Correct.
then
Correct.
25 and gradually increase the rate
Correct.
as we do it for rituximab. Yeah.
So, one very important tip which has been given by Dr. Preetham, first understand that the label itself suggests that the doses vary about depending on the weight of the patient. Most of our patients are below 80 and the dose is 1050 mg. Now, you dose this patient the first dose on day 1 and day 2. Don't try to dose it total. On day 1, you give only 350 mg. If the patient tolerates, then you give 750 mg in the day 2. You give pre-medications. Now, there is something very important. If you see the label will say to start from 2450 ml per hour. But practically, those who have used will start from 12.5 ml per hour. Because if the patient slows reaction, you have a chance to know that in the first cycle itself, around out of the 60%, 54%, which means 90% of your reactions will happen in the first cycle. Now, another interesting thing about amivantamab is, see, when we give Pacli or we give the reaction happens in first 10-15 minutes. The median onset of reaction with amivantamab is first 1 hour. So please don't get overconfident in first 30 minutes that the patient is doing well and give assurance to the patient कि अभी आगे कुछ नहीं होगा. Let it be monitored. Now, this is the risk mitigation strategy which was pointed out by Dr. Preetham, that you give antihistaminic, you give antipyretic and you give glucocorticoid to these patients. Now, what are the kinds of reactions which you see? And Rohit, if you see one of them, what you need to do?
Sir, I think very classically you have allergic reactions, breathing
Correct.
issues, and BP fluctuations, etc. So, sir, cytokine release like we see with rituximab essentially.
Correct. Correct. So this is the chart which tell you that if you have grade 1 and grade 2, obviously like any reaction, you hold the reaction, give anti-allergic medications, and wait for the reaction to go to grade 1 or grade 0, and then you resume at 50% of the infusion rates. Now, if you have a grade 3, then again you can hold it, give medications, again resume it. If you have a grade 4, then you may have to permanently discontinue amivantamab. Now, this is what I'm going to tell you in grade 4 is my personal experience. This is not from what the label says. I have treated grade 4 with amivantamab after doing classic desensitization over 12 hours. And the reason why I had to select 12 hours is because the product once diluted is according to the label is stable only for 12 hours. Now, this was a genuine problem of how do you see in Exon 20, the data from Tata, which we published a few years back, the median OS was only 4.5 to 5 months was the range. So if you cannot give an effective therapy, it would be difficult for these patients to survive. Now, amivantamab is the only effective treatment in this disease at this point of time, and reactions were an issue. So this skipper was a phase 2 design study, which was actually to see how we could cone down on reactions with amivantamab. And what they did was, they gave dexamethasone 4 mg, dexamethasone 8 mg, they get montelukast, and interestingly they even get methotrexate. And this is a phase 2 design where it is actually a Simon's 2-stage design. Now those of you know about Simon can have a 1-stage design or 2-stage design. 1-stage design means you recruit few patients and you say if this many patients don't get reaction, it's my success. And if you get that success, you recruit more patients. And that's why you say stage 1 they enrolled 6 patients. In stage 2 they enrolled 10 patients. So the total, and after that they went for an expansion cohort for 24 patients. And the primary endpoint was reactions. And these were the secondary endpoints which were being seen. Now, why was the rationale for these interventions? Now, I am not going to explain you the rationale for dexamethasones, neither I am going to explain you the rationale for montelukast. The montelukast data specifically came for daratumumab. Those of you who even did multiple myeloma will know about the data. It has been, they even added methotrexate because they saw that in patients who were receiving infliximab, methotrexate addition in these small doses actually led to a decrease in side effects. Now, what we are seeing here is the initial results which we are going to see. And what we saw with 4 mg is IRR was 5 out of 6. Which we saw with 8 mg was IRR of 2 out of 6. What we saw with montelukast was IRR of 3 out of 6. When I say 3 out of 6, means 3 got reactions out of 6. What is the point I'm trying to tell you is that if you are going to use dexamethasone, the dose of dexamethasone has to be 8 mg. And not 4 mg, because 4 mg clearly the study shows that it does not work. If you are going to use montelukast, it is still a reasonable, but if you could see that it was only dexamethasone which went up to the stage 2 and yeah. So at present we do not have to be very what you could say extravagant of trying to use montelukast or for methotrexate for a. We can stick with what Dr. Preetham told, but just to see that the dexa dose is around 8 mg in this, and this is what passed the expansion stage. So this is the prophylactic schedule which if you use, where this is very similar to those of us who got trained in the early decade of 2000, where when docetaxel was given, where the classic was to give 1 day prior the patient used to take dexa, and then it's very similar to that the patient takes schedules before and then in clinic you give dose, and that has reduced the incidence of IRR from 67.4% to 22.5%. Now understand, in Exon 20 at present there is nothing else which works. So it's very important that we administer this to the patients, because many of these patients after going through the horrendous experience of such reactions may not be willing to take further cycles. So, and such simple interventions in which you could use dexa 8 mg would able you to give amivantamab in Exon 20 insertion safely. If no, then frankly the patient, if he's in June, he's not going to see the new year, and if he's in near December, he may not be able to see the next whatever happens in July or August. Yeah. So this is what we need to understand, and this is the first thing which I wanted to. Now, I don't know when this comes, but you have development of subcutaneous amivantamab with intravenous amivantamab. And the reason why I wanted to show you this study is because this study, very interestingly, is not looking at OS, PFS or anything. This study is actually looking at non-inferiority of subcut amivantamab, and that is a co-primary endpoint, which is a pharmacokinetic study. But even for a pharmacokinetic study, interestingly, the study has a very huge number of around 400 patients. And what it will lead to, it will make sense to look at the secondary endpoint analysis of this study also. And I won't bore you. What it is showing is, if you give even subcut, it has similar pharmacokinetic properties. And if you give subcut, it has similar efficacy parameters with respect to the response rates, progression-free survival, and with respect to the overall survival. If at all, it seems to be slightly better than the IV preparation. Now the interesting thing was in this, where when you use a subcut infusion, the rate of at present the discontinuation came down, and also if you look at the allergic reactions, it also came down. Now this is very clearly showing you the rate of allergic reactions. Now let me come back to Rohit. Now Rohit, we know that okay, you use subcut, you use DEXA, incidence comes down. Another important thing which goes with amivantamab is venous thromboembolism.
Yes.
And what do you do in your patients who are going to receive amivantamab about venous thromboembolism prophylaxis?
So I think, sir, in the trial also prophylactic anticoagulation was given in the initial phase of the trial. I think we should consider that because that is a significant.
Correct. So please understand when you are going to use amivantamab, okay, and if you are going to use a regimen of amivantamab, pemetrexed and carboplatin, I classically say that it's not a 3-drug regimen, it's actually a 4-drug regimen. The 4th drug is anticoagulant. You need to go give anticoagulant to these patients, because if you don't give prophylactic anticoagulation, 1 out of your 4 patients with amivantamab is going to land up with PTB. Okay, so venous thromboembolism is important, and you need to give prophylaxis for the same. Okay, and with that we'll come to now Sangeeta. The next thing which actually happens, which is again, okay, I don't have slides for that, is rash and paronychia. Those of you which you have given amivantamab will know that reaction can get managed, VTB gets managed, paronychia and rash and edema over the foot, which are because of the MET-related side effects, they are very difficult and the patient quality of life hampers. So what do you do in your practice for the same?
Usually we interrupt the cycles, sir.
Okay, so Sangeeta says, I interrupt the cycles. Okay, this patient also is happy, I am also happy.
I mean, see, rash is something very difficult, but then if they are non-itchy rash and if the patient doesn't have the discomfort, then we always continue. But if there is causing a lot of discomfort, we definitely interrupt it.
So that is correct. If it is grade 3 or grade 4, it causes discomfort. I don't have the slide set. I think J&J, in spite of my request, forgot to give on that slide set of rash management and all. There are good mitigation strategies which have come with respect to prophylactically giving antibiotics, and I would request them to share with you all, and if they can share with me, I'll put in the group so that you all can have that. You want to talk about that?
Of Cocoon trial. So we are going, the trial is going on, Cocoon trial, where we compare the proactive skin management versus the reactive skin management, and where we gave the prophylactic antibiotics, topical antibiotic for initial few days, and then the systemic antibiotic, especially the tetracycline group of antibiotic, and then the moisturizer and the chlorhexidine gel for the hair rash, and we are expecting, sir, that all the dermatological toxicities will be much lower with amivantamab with the proactive skin management. So since the data is not out yet, and we are expecting the data in ELCC next year, so that's why, sir,
So
not
he has MNC policies. I don't have any of those policies. So I was privy to some of the interim analysis which have been shown and did actually looked good, in which giving chlor-exiting shampoos for this
It's
patient.
like giving doxy for those erlotinib
Correct,
patients.
that was something we used for
Doxy, which
doxy.
we used to
So
use.
basically like cetuximab, we give,
Cetuximab.
yeah.
It was something very similar to the step protocol which was got developed with cetuximab. Very similar lines it is getting developed, which actually if you see that it is very difficult if you have a patient on long term on amivantamab, which they go to get pustules in the
Scalp.
scalp, and in fact they cannot even do shampoo. I remember one of my patients, whenever I used to shampoo, he used to do the CBC next day and tell me, देखो मेरा hemoglobin drop हो गया, because a lot of scalp gets sometimes it is even it gets infected, and the quality of life of the patient gets bad because it stains very the order is not good. So these are things which impact the quality of life of the patient, the paronychias, in fact patients cannot walk, this gets swollen. So it's important that we have, because see in exon 20 now we don't have many options. So we need to see that how best we can give amivantamab in this, and any prophylactic thing which prevents this is great. Now with that we have some time left, and let me take an opinion from the house. So what is your standard today for EGFR Exon 20?
Standard is what is already the guideline, but then on a routine practice, I don't think even 10% of my patients are affording for it.
No,
So-
we are not talking about non-affording patients,
Then
Sangeeta.
it is definitely chemo with amivantamab.
So you want to give amivantamab, lazertinib to all your patients?
Chemo with amivantamab for
No,
the
I'm not talking about Exon 20 now. Exon 20,
You
over last
talk-
4 minutes we talk about upfront patient. EGFR 19, sorry, let me make it. We are talking about EGFR, TKI sensitive mutations, and commonest of them will be EGFR 19 and
So
exon
we are switching on from the osimertinib to this amivantamab plus lazertinib.
How comfortable you are, Sandeep, to make the switch?
osimertinib will be the definitely first choice.
Okay. No, he is very clear. Osimertinib will be the.
Sir, probably Flora 2
Flora
now with the
Flora 2.
osimertinib plus
So-
PEM platinum.
Yeah.
Yeah, I think the Flora 2 trial.
So one of the things which we need to understand is that, okay, osimertinib alone may not be the best option for most of our patients, especially if they can tolerate chemotherapy. Either it can be the Flora 2, or once lazertinib gets available, it may be amivantamab plus lazertinib. Now,
So after progression of osimertinib, what is there? So I think amivantamab plus. So that
so Preetam has already planned that if the patient would progress on osimertinib and this, and hence he is reserving amivantamab for the later lines of therapy.
We used to do when OC came, use Jeff first and keep OC later, but then we eventually switched on to OC for
Sir, I think chemo with TKI we have been using, and we are confident in managing side effects and all
Yeah.
that. So probably I think
So
maybe.
probably till lazertinib becomes available, lazertinib also causes quite a bit of neuropathy and has side effect related issues, and we become comfortable. Chemo with TKI might remain the option for most of patients who are affording. Now let me throw this to, and let me ask Rushabh. Rushabh, if you have a patient of exon 19 and who has a P53 deletion, so exon 19 with a P53, what will you offer? Funds is not an issue. That's why you did it from Guardant.
So, only OC is not a choice in that case, OC plus chemo or ME plus lazertinib.
Yeah. So please understand that today, if your patient's financial concerns are not done, there, do not make decisions only on looking at the EGFR. Please also look at the co-mutation burden. Question to the panelists, and let me ask Preetam. Preetam, if you have a patient who has multiple brain mets, and he is saying that finance is not an issue with me, would you want to put the patient on OC plus chemo, or you want to put the patient on amivantamab plus lazertinib?
amivantamab plus lazertinib.
Yeah, so that would be one subset of patients with it.
Very, yeah, that's right.
And this question again, I would want the J&J people to act. Amivantamab as such is a large molecule, but we have been privy to data which show that amivantamab also in patient with brain mets has activity. And how do you explain that?
Sir, the possible explanation is the immune-mediated activity of amivantamab. It has been shown in the data that amivantamab activates natural killer cells as well as the macrophages, and through antibody-dependent cytotoxicity and the trogocytosis, it enhances the cancer-killing mechanism of these cells. So that is the possible mechanism, since it does not cross the blood-brain barrier. So same as that of immunotherapy is what has been seen with immunotherapies.
So actually that was one of the questions my patient who had brain mets had asked me. You are giving me an exon 20 amivantamab, but it does not cross the blood-brain barrier. But thankfully by that time in the ESMO last year you had presented the data of amivantamab in brain mets already. So does anyone have any questions? Related to exon 20, related to EGFR upfront, related to amivantamab, lazertinib? If not, so I think to summarize this discussion, it's very clear that in exon 20 insertion, at present amivantamab is the only option which gives a survival benefit to the patient and a respectful progression-free survival. Now, and hence we need to know how to manage this drug properly. Infusion-related reactions have to be taken care of. VTB prophylaxis has to be given, and you need to be proactive with the paronychia management and even with the management of the skin rash in these patients. Now, if you have an upfront EGFR, you have multiple options, but if you have especially a co-mutation on what we call the high-risk disease, today FLAURA2 option or amivantamab plus lazertinib when lazertinib becomes available in India would be the good options to go. But if your patient definitely has brain mets, amivantamab plus lazertinib in an upfront patient seems to be a much better option even than the FLAURA2 option. With that, I think it's our time. I thank the panelists for the good interaction and the J&J people for answering our queries. Thank you.
Thank you, Vijay. From whatever we understood, it was great.